some people here that know about TB, but I just want to give a really quick background on the TB situation so we can see where these synergies are with universal healthcare and where the gaps are, because I think that's going to be key in thinking about how to make this happen. There's 10.4 million people that get sick with TB every year. And right now, the system that's in place is that you wait for sick people to show up at the doctor and then do some very minimal screening of family members. So as a result, only 6 million people roughly get diagnosed. So a lot of people are left. Now, you know that TB hits people in very, very poor communities. And so there are very few systems in place in countries to go out and find those other 4 million missing people that you know have active disease. So 4 million people go undiagnosed. There's a lot of drug resistance. 1 million get TB, and only 1/3 of them are diagnosed. So really very few systems to go in and actually screen children who are at very high risk of TB. And so, as you know, it should probably come as no surprise that 1.8 million people die of this disease. It also is the biggest killer of people with HIV. Now, if you get infected with TB, you don't always get the disease, right? You sometimes just get infected, your PPD goes positive, and you don't get sick. 10% of the people who get infected actually get the disease. So the pool of people who are infected also becomes really important, right? So what is that pool? And very conservative estimates say that pool is somewhere around 1.5 billion people. Less conservative estimates say that pool is 2 billion people. So when you start to look at it, there's between 150 million and 200 million people who are going to activate their TB. So this little piece of 10.4 million is just a tiny piece of the other 150 to 200 million people who today have TB in their body and are scheduled to activate. 5% of them within 2 years, and another 5% later when they're elderly. So a really big pool and a really big problem. Now, if you start to look at the global rates of TB, they decline at only 1.5% per year. So this problem hasn't been dealt with sufficiently. And I want to just go into, like, for 5 minutes why it hasn't, and then we can think backwards to the synergies. Okay, so there's been a cure for TB since 1943. I mean, it got operationalized in 1944. It got put into patients in first clinical trial 1947. So by the late 40s, you could actually treat this disease. You could treat this disease. And slightly later, you could treat it well because other drugs were created and you know, people figured out a few things. And I want to go through what the things that they figured out were, because this plays into what kind of disease TB is. People figured out that if you gave one drug to people, they got drug resistance. They figured that out. The first clinical trial that was done by the British Medical Research Council showed that up to 40% of the people got resistance. So people figured out that you actually had to give the multiple drugs. So this tells you something about the complexity. It's not like a vaccination. You can't just throw something into somebody and walk away. You have to give multiple drugs. And in those days, it was for 18 months. And people, you know, again, there was a new drug for TB, not a new drug in general, had come out, isoniazid, in 1951, and they gave it to people and they got cured. And again, immediately after they got drug resistance. So, and every drug on that list that I showed you, people tried to use alone, and then immediately after saw that there was drug resistance. So people realized that you really, really had to give this together, which meant that there was some complexity to this. You had to have supply lines, you had to bring drugs, and it had to continue over a long time. And people knew that literally from day one. Now, people, you know, a lot of people thought, well, you know, when you get resistance, you get kind of mutations in the chromosome, right? So if you get these mutations, maybe this bug will not be as strong, right? It'll just die. But the British Medical Research Council did a survey in 1955 where they found quite high rates for the moment of primary drug resistance transmission. So streptomycin had just come out, isoniazid had just started being used, para-aminosalicylic acid had just started being used, and yet they found resistance to all of them around, you know, 1.5% to 2% in the community. So from very early on, people knew that these drug-resistant strains, if you created them by not giving proper treatment, could be spread in the air to other people. So very, very early finding. And similar data in the US as drugs started being used. And people thought, well, if they spread, maybe they'll revert back to, like, you know, not being that deadly. But that didn't happen either. And then the other finding that was really interesting, and again fits into this primary healthcare picture, is that they found that when patients were started on an effective regimen, they were less infectious. Sounds pretty logical, but you know, people thought, well, how quickly do you need to start somebody? And then if you start them, you can still find bugs when they pop up, and you look at it under a microscope. So maybe there's a certain lengthy period where there's still infections. So Richard Riley did a bunch of experiments between 1956 and 1960 at Johns Hopkins University. And he took patients and put them in a room and took the air from the room and put it into a chamber of guinea pigs, which are very sensitive to TB. And he found out that these guys had come in, they were very sick, and if they weren't treated at all, 100% of the guinea pigs got infected. But if you treated them for 24 hours, like literally just put them on the drug, and they still, if you looked at a microscope, you could still see the bugs. They became almost not infectious if you put them on the right regimen. And he did a number of experiments, which I'm not showing you, where people were on the wrong regimen, and this didn't happen. So it really was being on the right regimen as quickly as possible. So you can see what's happening here. You got to give multiple drugs. You got to get these people really rapidly on the right regimen to stop transmission of the disease. And then another observation that happened is that people would treat a family with somebody in the family with TB, and they thought, okay, problem solved. We've gotten there. We've screened everyone in the household. This is going to be great. And then 6 months later, or 8 months later, you would have, somebody get TB in the household again. And some people thought, this could be this pool of people that I mentioned, this billion people. This could be people who are infected somehow, but they're kind of like the bug is dormant. That's what they were calling it, dormant bugs, dormant phase. It later became called latent. And we now know from research done here at the med school and the School of Public Health that it actually is not dormant. It's actually active. But in any case, a scientist, George Comstock, in the 1950s, when the United States Public Health Service started treating people in Alaska, in Bethel, Alaska, they went there and they set up a hospital-based system. By then, the Indian trials that were done in Madras had shown that you could do a community-based system. So they quickly shifted to doing a community-based delivery system, and they started screening people in the community with X-rays and treating all active disease. And then they noticed that those same families were getting TB. So what they did is they said, why don't we figure out how to kill these dormant TB bugs? And so what they did is they said, why don't we give isoniazid prophylaxis, which had never been used. And they gave it, and interestingly, the combination of giving isoniazid prophylaxis, having the community-based treatment, dropped the TB rate. The TB rate in Alaska was 2,000 per 100,000. Crazy high. The United States rate is less than 3. It was 2,000 per 100,000. And using this combination in a place that was poor, with poor nutrition, overcrowded housing, they brought it down, like in the span of about 5 years, to 149 or 146 per 100,000. Today, Bethel is at 9, which is still high for the United States, but obviously very low. So they brought it down tenfold, more than tenfold, very, very rapidly. This is a slide of TB infection in children. They used, children are a great proxy for transmission because they can usually only get it from their parents or close contacts. And when they started doing this combined therapy, infection of kids under 3 years old just dropped almost to 0. So they showed. So these were the 4 observations, and they were pretty straightforward. You should search for newly infected people amongst contacts. You should start therapy quickly and get the safest, most effective therapy. You have to, of course, make sure they take it because you have to take it in those days for 18 months and 6 months, and you have to treat all the contacts. So really simple, basic stuff. Okay. And we used all of that stuff here in the United States, and it really became part of practice here and in Europe and in a lot of places. And that's really why TB, in addition to economic growth and housing and things like that, TB really dropped here. Okay. Now, we haven't been able to stop it globally because something happened, and this is the rift between the TB, as I've explained it to you, which sounds somewhat like a complex health intervention, and primary health care. So we all know that, the primary health care movement, I'm sure Rob talked about this, had high hopes. And one of the high hopes was let's use exactly, at least what we know, a very basic technology, which TB was really using basic technology, all the different microscopes, things like that. Let's use what we know to alleviate suffering amongst the poor and have this really base primary health care. Something happened after that, and that is, it was a historical moment, it was an economic moment globally. After the oil embargo in the early 70s, the economies of Western countries went down. So by the time Almata actually happened, and it was in the planning and the works for, really almost a decade, by the time it actually happened, the economies of Western countries had gone down. And right after Almata, Rockefeller Foundation, amongst others, got together and said, can we actually do primary health care? Although it was minimalist by most standards, it was somewhat, it was going to be for everybody. And these guys got together and said, we don't think you can do this. And Ken Warren was the head of the Rockefeller Foundation. And they said, maybe we need to have an interim strategy. And that would just be that will get us to primary health care, but let's start. And they started saying, well, why don't we put disease in priority groups, like high priority, medium priority, etc. And the high priority were the things that you could fix really easily, where you didn't have to build the health system, but we're killing tons of people. So that you could give a vaccine, say for measles or something, and that would become a high priority. And then the other stuff, they actually, said those things, they're expensive and difficult to administer, or the drugs are toxic, and you actually need more research for them. And it was leishmania, African trypanosomiasis, TB, things like that. So they said, let's put this aside. And so a lot of people at the time, UNICEF bought into this, wholeheartedly, because it really fit, it fit well with what they wanted to do, which was stop kids from dying from preventable diseases. And so you had this whole, throughout the 1980s, there was, people really bought into this, what became called the selective primary health care. It was supposed to be an interim measure, but it ended up not being so interim in the sense that it kind of became what donors and other people were funding. And so TB kind of fell off the agenda from, what are our priority interventions to fund, if you were a big funder. And that went right into the 1990s. The World Health Organization, I'm not going to go into the entire history of this, but the World Health Organization in 1992 declared an emergency. And they said there's 9 million cases of active TB a year. Now it's 10, so it was 9 in those days. And 1/3 of the world's population, they said 2 billion people, are infected with this latent TB. So they declared this emergency, and they launched a program that had been developed over many years, where you gave drugs, the TB drugs, many of which now were off patent. And in fact, the treatment had gone down from 18 months to 6 months because rifampicin was really, really effective when given in combination with other drugs. And it had gone off patent. So they created this package of treatment that had been tested in East Africa, where you could give it in a little package. You're a community health worker, go to the patient's house, give them the medicines, and you do it every day. So it was kind of the equivalent of doing a shot. I'm talking about resistance and finding and all these things. You find the sick person, you go, you look after them, you give this package, and that's what they created. They created this package. And the package, in some ways, was amazing, and in some ways, it was bad. I just told you they went to people's houses. Now, allegedly they went, because it didn't happen everywhere, but they went to people's houses, or people came to a clinic. So there was a linkage between the community and the clinic. So in a sense, that was very positive. And they built that. They got governments to commit to this. They tried to put diagnostics in places like sputum sphere microscopy. This had a sensitivity of 50% in regular people, 20% in children, 20% in people with HIV. So at the time when the HIV epidemic was killing people, this was really frowned upon by many. The fact that children were being excluded was frowned upon, but it did find half the people that otherwise may not have been found. And you'll often hear a statistic where people say, oh, God saved 47 million lives or whatever. That's the half that this really did find. And it's hard to tell if it was just using this, but this was one method. They made sure that there was supply lines for these drugs, these 4 drugs that I told you about, that they didn't treat drug-resistant disease, but they treated regular disease in most of the cases, and they made sure that the countries that signed up to this got medicines, which was great, because one of the things about the primary healthcare movement is they actually get medicines. So they had standardized therapy, they made sure the drugs were there, and they actually had people report. And it fit into this paradigm, and it fit into the economics of the moment, which was that it was simple, easy, low cost, right? And it really, the one thing was that it was also siloed. It wasn't built into the healthcare system. It was completely separate. And so this is where we now have to say, okay, we've got the system, and it's very rudimentary. So it didn't deal with any of the complexities that I told you about. There's no active case finding. There's no drug-resistant disease things built into the system. There's a delivery mechanism, which is great. There's no treatment of contacts, for latent TB. Okay, so you do get a delivery, you get adherence with supports, and I don't want to underplay the fact that you get probably 90 or 95% of the people at the time getting some form of treatment, and ostensibly many of them wouldn't So we sat down and said, okay, we know that the system has made sacrifices, right? What do you need to do to actually eliminate the disease? We resurrected these things that I just showed you, these 4 ideas of all these things that you have to do, and it came out in a Lancet series of how to eliminate TB. And the question we now have, and I think this is what brings us to the discussion today. Oh, sorry. Um, People at the World Health Organization, colleagues of ours, Chris Dye, Philip Westwood, Captain Floyd, and Mario Robinho, they have modeled this. So this isn't like stuff that we're just imagining here, in some room at Harvard. They've said if you continue, this is the baseline. If you just look at risk factors, you get this. If you actually treat active TB, a curve that looks like this, that TB will reduce at this rate, which is really what it's reducing now. And if you actually treat active antigen TB, you get this massive drop, which actually seems to go close to elimination. So, our colleagues at the WHO, people who have been working on this for years, like we have, feel the same way. Everyone recognizes this. So what we did is we've taken this knowledge and we've said, look, can we put this together in something that people can do? And we've created something called the Zero TB Initiative, which where you take the search actively, test properly, treat effectively, and support people through treatment. So exactly the same stuff that was found out in the 1950s. Nothing new, unfortunately. Prevent exposure and treat exposure. Prevent exposure through infection control and treat exposure through giving people this prophylaxis. Right? So just a really, really simple system. So now we ask ourselves, how do you operationalize this? Right? We've got this siloed system that's got some pros and some cons, and you need to operationalize something which I've shown you is a little bit complex. And how do you do it? So, very much similar to the primary healthcare movement, when we were sitting down thinking of the Zero TB Cities initiative, we said we need to have some underlying principle behind this, not a health delivery principle, but a moral principle that's going to frame this, because people are gonna say, let's cut corners, and of course one has to in real life. But what are we saying that we want this to do? We said that people in other countries are not a different species than here, right? So if we think that 3 or 4 or 5 things need to be done that are critical here, we should try and figure out how it should be done there, and that we really want to not discriminate against people based on their race or religion or national origin. So if you happen to be in India or Bangladesh, you shouldn't really get different care than in Denmark as far as like what the base, the underlying basis of the care. And so we thought, the current system has been very oriented towards guidelines coming from the global north, usually based in Geneva at the WHO, and they kind of just trickle down, and then countries, usually local elites, take it and translate it and give poorer people care that many of us would consider substandard. And we thought, how do you change that? Like, could you deal with a political unit that's closer to people, that actually sees these people and really has to deal with them? And we realized that cities have been doing it. And, I have to say that you could focus on other things, but there have been a lot of people that have been focusing on relationships in communities, which has been one of them with BRAC. People realize that you can get better care in the community, and you create systems at the grassroots. You're going to actually get better care delivery systems. And we said, how can we take this and operationalize it on a bigger level? And so we said, well, what about cities? They could think 50% of the world's population. They have their own resources sometimes, right? They are linked to public and private sectors. And when you're thinking about this, we have to think about primary healthcare because it's a similar thing. And they produce a lot of GDP, so they have money. And if you started to look at TB, you see that a lot of the countries that have the 60% of the world's TB cases actually have a fair number of people in cities, population-wise. Sometimes, 1/3 to 1/2, and it's pretty, so if you started with cities, it doesn't mean you can do this exclusively, but we said, if we could start with cities and create a system to deal with TB, this would be a step towards writing, what we thought was a previous one. So we created an NGO to push this forward called Advanced Access and we started something called the Zero TB Cities Project, and then we later called it the Zero TB Initiative because some islands like the Maldives and other people wanted to join. Okay, so what is this? And then let me link this to primary healthcare. So I told you that this comprehensive program of care, right, that we need from the 1950s and 60s. We thought, well, why don't we try and have as one of our foundational things, comprehensive program of care. Search, activate, treat cohorts, prevent progression, provide care across the spectrum. That's not easy, right? That means that you actually need to create a mechanism to go to these households. So you get an index case that shows up when they're sick. You need to go to their household. You actually need to screen them. Well, I told you speed of smear microscopy is 50%. It costs $1.50 a test in India. So you need two of them at least. So that means it costs $3. We found out that X-rays, which tend to be more effective and can identify more things, cost $2. And actually, when we started talking to some of the X-ray providers, they said, if you give us volume, we'll bring it down to $1 or $1.50. We're talking rupees, translating it. And so we realized, okay, we could do that, but then you need these X-rays to go somewhere. You need somebody to interpret them. You need positive, you need somebody to back them. You need to make sure that you have the drugs for TB. You also need to make sure that the people who are exposed to TB or may have TB even though they think they're healthy take drugs also. So you suddenly start to realize, oh, well, this is a mechanism to extend the clinic into the community and ensure people are doing it right. And by the way, this is not like, these are not like earth-shattering things. Richard's written a book about this with Brack. Brack was doing this. We're just trying to figure out how do you package this program and how do you link it then to bigger things. Targeting households and the places where patients seek care. You know, households, it turns out, have TB rates of 1 to 5%, 1,000 to 5,000 per 100,000, the same as Russian prison. So if you look at the households, now people say, oh, there's migrants, there's this, there's that, you can't do all the households. But it turns out that in India, 68% of people live in fixed households. So, you know, you're not going to get everybody, but you get a lot of people, right? So, and then you focus, you know, children in the households, and then hospitals and clinics, outpatient clinics, have rates of TB of 5 to 10%, depending on what clinic they are. So again, you're starting to say, wow, 5,000 to 10,000 to 100,000, that's like a deep, you know, like a South African mine, right? So you start to say, well, these are kind of the low-hanging fruits, and there's probably many more. There's probably mines and garment factories or whatever, but we said, well, let's just start here. And then we targeted municipalities. We said, instead of going through the WHO and central governance and all this kind of rigmarole, why don't we go to people who are working with these people? And so as a test, so we were thinking about this here, and as a test, we went to India. We said, let's go to India, because Richard always told me, you guys don't work in India. India and South Asia's got 1/3 of the world's population, or half the world's population. So I thought, if we're going to launch this program, let's do it in a place that's going to be hard. Maybe it won't work. So we went to India. We went to Ahmedabad and Lucknow and Mumbai and Delhi. We spoke to the city government people, and they were like, yeah, we're going to follow WHO policies. You know, it's hard enough for us to do that. Can I? Oh yeah, this sounds very interesting. We'd like to do this. And they said, do you know that we have 141 primary healthcare clinics around? Can we link this up? Do you know that we actually have you know, food huts and whatever that people come and eat? And could we link that up to what you're doing? And we were like, oh yeah, because we weren't thinking about that. We weren't thinking that they would actually offer these services. But it turned out they had it, and they had all these things. And then they said, are we going to have to buy X-ray machines? And then, you know, people in the room said, no, actually, where all these clinics are, there's like 14 X-ray machines around here. We just need to link up with them. Think of it, the Uber of X-rays. You don't need to buy an X-ray machine. You just need to ensure that it's good and that the results mean something and that they can be transported. Right? Uber doesn't own any vehicles, but we all use it. So we thought, okay, wow, this could be really interesting. You actually link up to existing resources. They don't have to put in more money. You know, it's a systems issue. It's extremely complex. But boy, could we do that? And municipalities, you know, the WHO was like, well, you can't make a deal with pharma. You can't do this. You can't do that. We don't work with these people. The cities were like, oh my God, could we ask a pharma company if they'd lower the price for us? We were like, really? You want to? Even in India, there's this big allergy to working with pharma. But the cities were like, no, we want to do as much as we can. So we were like, okay, and we would use this to create a platform for community-based delivery of TB care. Okay, so you're probably asking why am I at a UHC conference? And so we've been working on this for a number of years, and now actually we have 46 cities that have signed up. After Chennai, Karachi got $40 million from the Global Fund they started, and branching out to Pakistan. South Africans have expressed interest Zhou has started, Lima has started. China, the Chinese came to a bunch of our initial meetings, the guys from the China CDC, and I just went there, they invited me there this summer, and they said, we are going to start 31 cities. 31 cities. So it's remarkable because they said, this might be the path. And I'll tell you why they're interested in this, because I think, as Rob just mentioned, they are rejigging their health system, and they're trying to figure out how do we get back to what we were doing really well 30 or 40 years ago, right? So if you start to look at a bunch of other diseases, and I'm just going to talk about compliance, because I know everything about health is not compliance, but compliance is a big piece. And the reason it varied, but if you look at breast cancer, people taking Taxol or whatever, breast cancer that kills you, right? After a few months of taking medicines, like half the people stop for various reasons. Diabetes, obviously, people think they're healthy and they stop. It goes down to like 10, 15%. In the United States and other places, multiple studies show this. Hypertension, statins, prostate cancer medicines, asthma medicines, they're all down here. People don't take them. So for every one of these diseases, the same thing I'm telling you about, giving healthy people medicines for preventive therapy, for every one of these diseases, right? It's exactly the same modality, right? So, and then we also realized that TB people, especially groups that we know, have been doing this for years. This is a community health worker giving an injection in a rural area, in an urban slum in Lima, in Peru. This is somebody that worked for Socios in Salud in the 1990s. This is this one. So we realized that we've actually been delivering care. We know we have systems that actually deliver care in places that are really tough to reach, with health workers that go. Here's a nurse talking to a patient. She's actually got a line innovation in a slum. You can actually do a lot of stuff. This is Russia. The research I've been involved in for the last 15 years, the delivery program, of a nurse going to a patient's house and giving care. And this is New Jersey. So we realized, and I didn't have pictures of Brad. This has been part of the TB lexicon, right? Linking the clinic to the community where patients live and work. And it's actually been going on for decades. So TB has a lot of faults, and I think it has a lot of faults, but it's got this system. And this system is golden because this is what you need for everything else. And so let's look at diabetes for a minute. Just 10 or 15% of people are taking their diabetes meds, right? What happens? You go blind, you get sores and get amputations. So countries like Saudi Arabia, which have a reasonable health system, have one of the highest amputation rates in the world. And you end up on dialysis. Right? So there's 700 million people with diabetes that they're on the path to this. Right? So we think TB, 250 per 100,000 in China. Diabetes is 13,000 per 100,000. In Dubai, diabetes is 20,000 per 100,000. This is what everyone's heading to if we don't create systems of delivery. And those systems of delivery, because remember, diabetics initially think they're healthy till you go blind, or you have kidney failure, or you have a sore. Right? So it's the same problem as TB. And so we've realized that maybe this platform that we're working to create in some of these areas is really a platform for health delivery that extends the reach of the community, putting into the community where patients live, but can really deal with a lot of these 21st century problems, if we want to call it that, because they've been defined now. Such as diabetes, COPD, heart disease, and diseases of mental health. It's actually creating a platform. And I'll tell you something, the guy in Chennai, the minister, the city commissioner, and you link labs, and you link all these things that we talked about here, maybe you couldn't even deal with this, because how are you going to screen people for diabetes and get the people on the right treatment? How are you actually going to get people who are poor to take medicines regularly? You're going to have to be creative. You're going to have to think about conditional cash transfers. You're going to do all sorts of things. I don't know what. But you're going to have to do all sorts of things that we have to do for this. But this is actually the entry point into here. And so in a strange way, we're taking this selective primary healthcare program, which is a community delivery system, and using it as the basis to do this. Now, we're not the only ones doing it. I was in Dhaka a few months ago, in one of Richard's friends came up and said, we're doing a lot of this. We're trying to do a lot of this. So a lot of people are thinking about this. But the unique thing, I think, is that we're really taking something that was selective private healthcare, and we are turning it around and saying, okay, it may be bad writ large in the sense that it doesn't do everything that it should, and it is very siloed. But it's actually a wedge that's opened the door to do this. And if we can do this right, it opens the door to now, dogs going to somebody's house. We've also realized that we've learned this in the United States very well. That maybe some people need an SMS. Maybe some people need the people who have phones get an internet portal. Maybe some people need a nurse to visit. Maybe some people need a phone call. So this kind of contact that makes people engage doesn't necessarily have to be a nurse going or somebody going, but it just has to be a contact. We need this desperately in the U.S. The VA for diabetics uses SMSs, and it's proved to be very successful. Turns out when you use SMSs in other populations, you actually need to know your population, figure out what to do, and create, it's not like you need a bespoke system. There'll probably be 3 or 4 patterns that one could use. But you really have to think about how to provide light care and heavy care. And I think we can use this TB entry point in the cities to really help build this and build the framework for this. The last thing I wanted to tell you is that, in the last discussion, when you're starting to think about the systems, TB comes with money because the Global Fund funds projects in these countries for now. And so you could use that money as a base to do some of this stuff. And, when I gave a talk at the World Bank recently on this topic, and they said, we talked about conditional cash transfers. Could you give families conditional cash transfers? I had the opportunity to have lunch with your friend, Richard, Grameen Bank. Mohammed Yunus. And he said, well, why give conditional cash transfers? You could do small business loans. You could train capitalists. If you know that poverty is a problem, maybe part of it is really getting them out of poverty, getting people to do small businesses in the community. So I don't know how to do this right. But I do know that in countries that have actually taken on the delivery and poverty, like Brazil, opportunities in Mexico, you have seen some very startling health results. And you have seen people not directly going back into poverty. So there may be ways that you could, this could be done right. And so, when you think about this, right now TB has money. And to have universal health care, and I'm sure Rob talked about this, I'm sorry I was late, you need to have a tax base. When you start to look at the European welfare state system, which is just an amazing invention. It's an amazing human invention. Really. It's an invention where you take the idea that we come together as a society and you pool risk, and you take it to a way that protects a lot of people. It's just probably one of the greatest inventions of the 20th century. Completely eroded now, I think, in many ways, but it was a great thought. But it requires a tax base, and it requires, arguably in Europe, people argue that it required some type of homogeneity and willingness to help others, etc. But if you put some of those things around, you need to have money to pull this off and create these systems. And then you also need money to sustain it. And that has to come from somewhere. So I think the reforms that take place, we can start it off doing things like this and try and find these synergies between programs that are siloed but actually have money flows. But then I think it really has to be taken up, either in cities or states. Anyway, let me end there.
Bring up your slide of the countries, you had just maps along the top of the countries that have got the most TB cases.
Oh, yeah.
I think, it's about. I would say those are the hit list countries.
Yeah, so we're pretty China's moving there as well. Indonesia.
The countries that we're looking at.
Yeah.
Actually, I would argue. About this, they are implementing reforms to re-socialize the financing system, and I think you mentioned so they're coming out quickly. The others are all underperformed.
and TV. Except for China. And China.
33%.
It's private
You think it's more?
financing. What I think, all of those are sort of low, middle income countries. And really, 85% is the solution. And global money isn't going to be material, I'd say. It
Yeah. The global fund is so small.
I know. Well, so WHC.
And I'll just give you a classic gap. I just told you the kids are not discovered to have TB. They're very hard, so kids have worms and all sorts of things. So how do you know you need to go to the TB doc? You actually go to a primary care doctor, right? And they're not doing what's needed. Now, it's hard to diagnose kids, but it's not impossible. And if you've tried other things and their kids not, they're still up their growth curve, it is something that one should do. But the primary care docs don't seem to do it. So you have very, very few kids that are actually diagnosed. So, and of course, we need better diagnostics. I'm not discounting that. But even with current tools in places where they are doing it, in certain centers, even in India, you do see high diagnosis of kids. And in Pakistan, you see that as well, like in this hospital or wherever, where they actually test kids. So that we need to integrate with these other clinics because nobody goes to the TB doctor unless they're coughing blood or they have a cough. And a lot of these people, and there's studies from the WHO which are quite remarkable. When they've looked at people in their surveys, when they do these prevalence surveys, something like half the people in some settings, more than half, don't have coughs. They have no symptoms. But when they screen them as part of the survey, they find that they're actually have disease. So if you're waiting, going to any doctor is a question mark, which is why you need active case finding. But nobody goes to a TB doctor unless they're told ultimately. So I think that that's part of the challenge that primary healthcare would do better. That being said, and I'm sure you've talked about this, and I know Joy has talked about this before, is that this multivalency. Doctors can only do so much. So these are complex things, and how do you do it, and how do you link it up? So people have asked me, do you think you should get rid of siloed TB programs? And I've said, well, I think you should get rid of silos. You probably still have TB programs because the doctors can find the people, hopefully. But then they need to hand them to somebody that can actually help do this complex management until they build the structures to do it. And I'm not sure how that happens. I mean, there's going to be a transition point, but there's got to be probably a time where we're really trying to do both. Richard?
Follow up on something that you talked about is active case finding and actually two people. When this was proposed many years ago for TB for HIV, for example, and there's no barrier to people stigmatize these people and so on. We did not find this environment. I'd like you to talk about that.
Yeah.
Is this stigmatization really that big an issue? Active case finding, active treatment in the community. You can't do that without identifying the experience.
Right. So, Richard, I think the way you set up the question, you're going to know my
I
answer.
I want to bring this out.
Yeah, I think
this is set up as a barrier to the very thing that you talked about.
Right. So I think we bring it, and we bring it in the form of having supported programs that have not provided good care. Because theoretically, what is the stigma that TB? There's nothing you can do to get rid of it. It's genetic, or it's bad air, and all of this stuff. It is bad air, obviously, but it's not in that sense. But there are So I think that what we found in Lesotho, for example, when we started our HIV program and our HIV TB program, we opened up at a clinic and nobody would come. One or two people would come, and we would start them on and they would go to hopping around and walking 5 miles to the clinic, whatever. And after 2 or 3 months, we had a lineup of people, like literally a line waiting at the clinic the minute you opened it in the morning. Which I think it's not unique to Lesotho; it happens everywhere, right? So I think human beings move towards efficacy. If you have back pain and Tylenol and whatever doesn't help you, you go to an acupuncturist and you start rubbing herbs in your back or whatever, right? Because everybody moves towards efficacy. So my sense is that if we actually were to show that this is good, we actually asked people. So as we were doing this, I went to different NGOs in China, some of whom are not partnered with us, and I said, can we just talk to your patients informally just to find out, what would help them? And we said, like, would you guys take medicine even if you weren't sick? And they said, well, would it protect our families from getting sick in the future? And we were like, yeah, hopefully get rid of the whole thing. And they're like, yeah, we'd do that. Now, even when people said, if you give these people money, we were talking about conditional cash transfers. People said, if you give these people money, use it again, through a translator, because I don't speak Tamil. But, I said, what would you use this for? And I'm not kidding, one after the other, as if it were scripted. But if I could use it, never get fruits and vegetables, ever. Every time somebody wants to help us, they give us lentils. And I just wanted to give them something. And I was really surprised. Nobody said I'm going to go visit my mother. I wouldn't care if they did, actually. I mean, it's their money, it's an incentive. But they actually were all like talking about high nutrition food, profit, which they have. So it was really. So I think a lot of these things we bring, and BRAC, as you pointed out, and as you've written, have hundreds and thousands of millions now. When you look at all the other countries in these programs, where community health workers going, everyone knows about it, it works, etc. So I think that if you can deliver a cure and put an end to all this stuff, then it's helpful. Yeah. Oh, by the way, sorry, one more thing. Well, so this is a brilliant question. So when we started this is the first step, right? And so, a colleague of Richards came to me in Bangladesh and said, this is great. We'd like to do it in the semi-rural area. What do you think? We want to adapt X, Y, and Z. And we were like, yeah, do it. You should do it. And the X, Y, and Z is what we're defining central. We're creating guidelines. Right. This year, we're creating guidelines for the treatment of TB. Next year, we're doing guidelines for the treatment of resistant TB. These are the guidelines that basically what we're doing is we're taking New Zealand, Australia, Europe, UK guidelines, England, Canada, countries that have we're looking at their guidelines and we're figuring out how to but we're using those guidelines on purpose because those are countries that are rich, they're countries that are white, they're countries that have gotten rid of these and we're really going for, we don't want to have different guidelines. Now, countries may say this is more they'll vary. I think that's where the variation will be. It won't be the vision of what needs to be done. So I think we're not going to let this step through what to do. And the same thing, we're striking deals. I mean, this morning, we're talking to different pharma companies. They normally go through the WHO. We've created our secretariat. We're dealing with them directly. We're giving coupon numbers. Deep discounts to the facility. So we're trying to negotiate big discounts, and we're trying to do that with the people doing the tests, and we're actually going to be working with the people making portable X-rays like Delft and other people. So So, we want to make it possible. So if you don't have 40 X-ray people in your neighborhood slum area, you may have to buy it. But can you buy it in a digital way that can be at a lower price? We're trying to make now. Joy and Michael and I, we've all worked on the Green Light Committee, which was something that's trying to do this for MDR-TV.
And we're still traumatized.
We're still traumatized from it because it was a centralized node of control, WHO, blah, blah, blah. We're trying to do this in an uncentralized way. Is it going to be successful? I don't know. We're trying to get coupon numbers from these companies and leave it to cities, and leave it to other people who are doing these projects and agree to follow guidelines. Could it fail? Will it fail? I don't know. I hope not. But we're trying to do different means of bringing people together in a less codified central node of control type of way, while still maintaining the standards that you speak about. Because that's the main thing. If you go back to business as usual, you might as well not do this. Right? And then the money thing, again, this is step one. Visualize a new country, like Israel does it, and Kenya does it, and Nairobi does it, and Mombasa does it, and Arusha, and what's the other big city in Kenya in the west? Anyway, if all Kenya cities do it, similarly, you've got all these people doing it, then very soon it's like recycling. It didn't start with a national ordinance to recycle. It started with communities saying we don't have waste stuff, and it built and built and built, and now pretty well every city you go to in America started recycling. Can you do the same thing that's more grassroots linked, that's linked to treatment literacy, that's linked to municipalities? And look at the stats that I showed you. There's a lot of people that live in rural areas. So, this is step one of a multi-step process. Yep. Last question. So, Aaron, I'm glad you're asking that question. And again, I can spend so much time in my others have spent a long time thinking about healthcare. But just from my own experience, one of the reasons that I was so pro this city thing is, Tom Nicholson and I started looking at recycling. We started looking at the Healthy Cities projects, for bike paths. And we're like, all these things start with cities. It's neat, right? Like they got this weird thing. People want to convince the people to want it, then it happens in one city, then the next city, right? And I started to look at our successes at Partners in Health. Where have we been successful with TV? Like smaller things where you get the mayor, the local guy in, and he's like, oh my God, this is so awesome. And Tom's, where they said, okay, yeah, we want to do this, and they did it, and the TV rates dropped 50%. And then we took that same thing to Bangladesh, obviously this package, and the TV rates dropped from like 70 to 15, right? And so then they were involved. And then now, even, you would think that for 15 years we've worked in Russia. We've influenced the national guidelines. They include us in all the guidelines meetings. They've taken stuff from our Trump's program and put it into law, to their, their precases, their laws. And still all the places don't do it. But yet, another province has contacted us, Vladimir, and they said, oh yeah, we want to do this. Can we do this? We're now starting to work with them. So I started thinking, smaller units, and Russia's got 83 units. Now, 3 of them will have done this. I don't know where the tipping point is. 10 of them, 15, I have no idea. But at some point it will tip, because if you have all these provinces that have brought their rates down by 60, 70%, and a bunch that haven't, somebody's going to say, what's going on here? Right? And so I think that's going to be, you need to create an ecosystem for this change. So I do think, could this be a model for starting primary healthcare? It's not to discount, Rob, working with these states. The state decides. It obviously has a bigger impact because there's money with it. But to have a lot of these things happening on the ground and learning from them also helps. Thank you very much.
Sorry to have gone right in there, and I think we're